on the bed with their leg all the way extended to look for gastroc tightness. So we want to know if their gastroc's really tight. If their knee is flexed and they're tight, it's probably soleus also. If their knee is extended and they're tight, that's gastrocnemius because it crosses two joints. And then we're going to look at inversion, eversion, range of motion. Obviously, topical anatomy again. The tibial physis runs just above the joint line. You can feel where the joint line is. It's that soft, squishy spot. So just above that is where, and your best access to the tibial physis is right here. Tip of the malleolus is there. That's, you know, probably 2 centimeters below where that physis is. You'll feel that curvature coming in, and you know that if you're up above, if you're way up here, you're above the physis, but right here is where that's typically going to be. On the fibula, you can usually actually feel the little indentation of the physis in most kids, and so you're just feeling for tenderness there. Tenderness here is anterior talofibular ligament. That's the one most commonly injured in an ankle sprain, and so you're going to want to palpate for tenderness there. Syndesmotic sprains, where that ligament that runs up between gets torn. Always want to check for proximal fibular tenderness. Palpate the full length of the bone, because that energy can go up and out the fibula. So that fracture in the fibula can be at any level or can be non-existent. So always want to palpate the full length of the fibula. And then I'll do what's called a squeeze test. I'll squeeze the fibula toward the tibia way up here. If it elicits pain down here, that would be suggestive of a syndesmotic injury and one that you'd want to have ortho see. I'll typically get weight-bearing x-rays on those, because weight-bearing is like a stress view. If it's torn, it'll pop out. So, we talked about those physes. The deltoid is rarely torn. Posterior tibial tendon, the vessels, you know about that. The base of the fifth is always very easy to find. Tenderness you want to elicit for there. So those are kind of the common things. Now for ankle stability, worthwhile knowing in the ER even, but also in the office, to get a sense of how severe is the sprain. So inside hand, the fingers cup the heel, and the thumb and my little finger and ring finger are kind of around it there. So I'm making kind of a cup for the heel. I'm just going to hold here. This is just hold. It's just home. So I'm going to pull forward, and you can see that he has a little bit of translation there. Have you sprained your ankle ever before?
Plenty of times.
Yeah, so he has a little bit of looseness to it. It's not bad, but definitely you can even see that it's translating just a little bit. You can see that the foot is in a little bit of plantar flexion. You can see that his foot is resting on my forearm. So I've got good control of everything. And he will tell you that I'm not holding on very tight, and I'm really not pulling very hard at all. So from that position, why don't you bring your camera over to that side, because this is, for talar tilt, you'll find that that's... From that position, I'm just going to take this hand and slide down like this. My long finger goes off the tip of the fibula. Right here, I'm kind of sitting where the talus meets the fibula there. And I've got I'm going to just slide my hand from being cupped there to my thumb and long finger actually gripping the talus, and I'm going to rock the talus and see if this space opens up. And conveniently for us, his actually opens up a little bit. You can feel that you can feel how my finger falls into a little gap, and you can feel the talus rocking, and he's making a face at me like, don't do that.
No, it doesn't hurt.
Oh, it just feels weird and not right, doesn't it? So we have a highly cooperative patient. So